Okay, so in this final lecture on ventilation perfusion, we're going to look at the effect of positive pressure ventilation on ventilation and perfusion matching. Just a reminder of the case, which we will revisit at the end of this lecture. And as I said, we've already talked about the physiology of ventilation and perfusion, variations in exercise and posture, changes with certain disease states. And now we're going to look at intermittent positive pressure ventilation and its effect on ventilation and perfusion. So what happens with ventilation and perfusion in positive pressure ventilation? So let's just think about what happens in the supine patient. In a supine patient, there tends to be a little bit of a gradient in ventilation from anterior to posterior. When the patient is lying flat, the anterior part of the lung is somewhat hyperexpanded and therefore less compliant, so there's less variations in ventilation with breathing up here, whereas down here the lung is less hyperinflated because of the weight of the body and the lung. So the lung here is less hyperinflated and therefore there's increased compliance, so increased ventilation at the posterior part of the lung. The same thing happens with perfusion. Perfusion is less up here because the heart is working against gravity and greater down here. So there's some matching, but as we said, not as well matched as in a patient who is erect. On top of that, there's a overall reduction in ventilation because of the pressure of the abdominal contents on the diaphragm, making the diaphragmatic movement less effective. So what happens when you apply positive pressure ventilation? So let's start with perfusion. Globally, perfusion reduces across the entire lung. And that's because with negative pressure ventilation, every time we breathe in, that negative pressure pulls blood into the chest cavity, increases venous return, and therefore increases right ventricular cardiac output. When we reverse that and provide positive pressure ventilation, the venous return to the thoracic cavity is impaired, and therefore the venous return to the right side of the heart is reduced, and lung perfusion is therefore globally reduced. This is also a regional thing, so perfusion is still less good on the anterior part of the lung and better in the posterior part of the lung, although it's globally reduced. What happens to ventilation? Well, when we push air into the lung, the positive pressure that air is coming in at fills the lung much more equally, and therefore rather than have this gradient from anterior to posterior, the lung is much more equally ventilated. As you can imagine, this increases ventilation perfusion mismatching because the lung is globally hypoperfused, but the anterior part of the lung is less perfused than the posterior part of the lung. But then on top of that, the ventilation is now equally distributed. So there's a gradient from anterior to posterior with regard to perfusion, but there's no real gradient in ventilation anymore, and that will increase ventilation perfusion mismatching. On top of that, there's an increase in global ventilation and perfusion mismatching because the lung is now well ventilated globally, but that global positive pressure ventilation has reduced perfusion. So both of these things increase ventilation perfusion mismatching. The bellows effect is just the negative pressure ventilation increase in both ventilation and perfusion through negative pressure, and both of these things are eliminated with positive pressure ventilation. So you can see that somebody who's been ventilated will have increased ventilation perfusion mismatching initially, at least, until the lung has a chance to adjust due to its regional vascular and ventilatory reflexes, as we discussed in the previous lecture. Alright, so let's think about a specific situation, which is ARDS, ARDS, acute respiratory distress syndrome. So just to recap, IPP produces uniform global increase in ventilation and a uniform reduction in pulmonary perfusion. But there is better dependent perfusion in positive pressure ventilation in the supine lung. Unfortunately, with ARDS, that posterior and basal part of the lung is often the most diseased part of the lung. So the lung that has the worst ventilation in ARDS is the lung that gets the best perfusion. And therefore, in the supine patient under positive pressure ventilation, in the supine patient with ARDS, we're likely to be maximizing ventilation perfusion mismatch, so we're making it as bad as it can be. On top of that, these patients tend to suffer from regional atelectasis, and they tend to have fairly high closing volumes. So if we apply positive pressure ventilation to them, when the positive pressure, during expiration, when the positive pressure is taken off, often the alveoli collapse, and therefore we don't get good ventilation, particularly in the dependent parts of the lung. So given these problems, what can we do to correct them? Well, the first thing is, if we could avoid positive pressure ventilation in these patients, especially with COVID patients, they actually do better. So using things like non-invasive ventilation, CPAP or BiPAP, can be better for them than using IPPV. Actually, turning them over helps, because when we turn them over, the anterior part of the lung becomes dependent, and that is where we get best perfusion. And then again, when we turn them over, the dependent part of the lung is also well ventilated, so we're now matching the ventilated part of the lung, the non-disease ventilated part of the lung, with the area of best perfusion. So prone ventilation is one strategy. Of course, these lungs are really non-compliant, and therefore high inflation pressures have negative effects. Of course, we can get barotrauma, but on top of that, the higher the inflation pressure, the more we inhibit lung perfusion. So we try to minimize inflation pressures as much as possible by adopting a strategy of high frequency, low vital capacity ventilation. So frequent small breaths rather than a few big breaths. And then finally, two other things. Remember, we said that the airways tend to close off at the end of expiration, so providing a bit of PEEP is helpful. And then finally, use of physiotherapy to help open the airways can be helpful as well. So what about this 24-year-old asthmatic? Well, remember, with his bronchospasm, he's going to have areas where the lung, small patchy areas, where the lung is very poorly ventilated, which would lead to ventilation perfusion mismatching. But of course, as time goes on, the body reflexively responds to that and shuts down perfusion to the patchy areas of poor ventilation. Therefore, when we start ventilating this patient and we open up all the airways, we are going to open up areas that are no longer being well perfused, and therefore we will increase ventilation perfusion mismatching, which would lead to hypoxia. Of course, once we continue this, after a few minutes, those areas, the body senses that those areas are now being better ventilated and perfusion is restored. Two other things to bear in mind. The ventilation pressures for asthmatics is often quite high, and therefore that leads to barotrauma, but also high positive pressure ventilation significantly reduces global pulmonary perfusion. And again, these things can cause hypotension and hypoxia, because if you have a poorly perfused lung, the pulmonary circulation cannot pick up enough oxygen from the alveoli. Okay, so that's the end of this short lecture series. If you have any questions, you can bring them up in class. We looked at normal ventilation and perfusion in disease states, and the effect of positive pressure ventilation on ventilation and perfusion matching. I hope this was useful. Thank you.